Day two, I want to welcome all the participants and speakers again. Our first Global Symposium here managed out of the US. Today's session, not an endoscopic, not a joimax session really. It is a fusion technology session. Where is endoscopic spine fusion? Where is spine fusion, minimal invasive spine fusion going? How does the market look like? And we do this with Integrity implants. To the housekeeping. Technical questions. Please ask questions. We're also going to have polls. This is an interactive meeting. We have a chat function below. We're going to type here some test questions in a second. So you can orientate yourself. Please don't hold back with any questions. We are excited to spend some time between the sessions to get those answered. Got a me or one of the faculty speaking up and really expressing your questions. So they get answered. We're going to have polls in between. Please participate. Help us make this interactive. And now to the meeting itself. I'm really excited to introduce Integrity. We have here a whole crew of Integrity today. Going to start with Mark Richards, VP of Marketing. Then I have Kevin McGann here on the screen, President, really in charge of the sales side, I believe, and then CEO and co-founder. Actually got this whole company started with his partner White Geist, Chris Walsh today, and he's going to present on behalf of Integrity and going to show his view on the future of minimal invasive spine surgery, potentially endoscopic assisted spine surgery, fusion surgery. Yeah, thanks everybody for joining. And Chris, I'm handing over to you.
Thanks, Max, and thanks to joimax and all the participants. We're excited to get going here. So, we're starting to see exciting technologies begin to intersect, and as one group of technologies improves, it opens and springs, a block, so to speak, for, new surgery. And so, minimally invasive has been a goal we've seen minimally invasive sort of rise and fall. There's been sort of an ebb and flow of it, whereas maybe in sports arthroscopy, it happened very suddenly. But I think now the technologies exist where we're going to see, the fulfillment of the promise that's been out there for 20, 25 years. And so the idea is to talk about minimally invasive, but also maximally effective fusion surgery. And so next slide, please. We're located in Palm Beach, Florida, and we've been in business for 4 years. And, our thesis when we started the company was that the math had to work for the implant to really be able to go into smaller spaces with implants that were optimal for fusion and to prevent subsidence. And so, it's how do you want a snowshoe footprint, yet you want to get it through the ship in the bottle. And so, for lack of a better analogy, how do you get the snowshoe down through the ship in the bottle to deploy? And so it comes down to the math. And so what we've been able to do with the FlareHawk implant is shrink the insertion profile to 7 by 7 with an expansion profile radially in all planes in width and height and lordotic angles to 14 width and up to 14 in height. And so that change in what we were able to do in terms of the footprint, I think has given surgeons a lot of confidence that they can get in there with an implant that's not going to subside. And we'll talk about our data in a little bit, but also one that has an enormous amount of aperture and the ability to post-pack your graft and to get adequate graft. We needed to get the implant through a cannula that we felt like was 8.9 to 9.9. Under 10 millimeters OD was Dr. Hansen Yuan, who's on our board. And, he had a ton of experience and globally felt like that was the number where things started to really move. If your OD of your cannula was under 10, you could really start to treat patients, truly minimally invasive. And the question was, what was the graft that was going to get on the other side? We're getting bone graft volumes with the FlareHawk implant in all post-pack. There's no pre-packing necessary. So, we're limiting nerve traffic, instrument traffic, and we're getting on average 10 to 15 cc's of various graft materials through. But the other big number to look at in terms of the math is what is the cost of goods sold, the manufacturing cost of the device, and how does that scale globally? A lot of these technologies that come out, for lack of a better word, are quarantined to the U.S. market because of the reimbursement. And so the real holy grail has been able to have a biplanar expandable device that has the capacity for bone graft that can be made at a cost that can scale globally, and in the U.S. to outpatient and ambulatory surgery centers. And so the FlareHawk represents the fulfillment of that. Keep going. Next slide, please. And so just a quick review. The device was invented by a Guidant cardiac stent engineer. So he had done stents, coronary stents for Guidant. And it is a two-piece construction with a outer shell made of PEEK currently, with a titanium shim that ride in tandem. And when the shim is inserted into the shell, it expands radially, and with 71% increase in height, with up to 56% increase in width. And so at that point, and you can go ahead and just run that slide again, the apertures that are created through the flexors in the outer shell are open up, and which allows an enormous amount of bone graft to flow through. And so we're using all sorts of graft material, bioglass, synthetics, cortical fibers, cancellous chips, a lot of DBM. And so it's very useful in knowing that not only are you going to get an implant that's got adequate footprint, but then that you can really fill it with the graft to effect a fusion. We've done over 7,000 of these with the FlareHawk 9, which is a 7x9 insertion profile, 9 width. But getting it down to 7x7 really allowed us to get through endoscopes and get into the Camden's triangle. Very often being able to leave facet intact in a more stable spine. When you look at the market, there's billions of dollars that have been paid in capital to complementary technologies such as robotics, imaging, diagnostics. It goes on down. You're starting to see people with virtual reality glasses. Is any number of technologies that make things more minimally invasive. But really, all of that super highway of technology has to merge into one lane, and that's that has to pass through the neuroanatomy onto the other side of the into the disc space. And what implant that you're able to get there safely is really going to be the fulfillment of all of those technologies that got you there. And so we're confident that the FlareHawk represents the first implant to really validate many of these technologies in endoscopic fusion surgery. Keep going. And so, Camden's triangle, and it's a controversial sort of anatomical geography. It's defined by different guys. Some guys just think of it as a transforaminal approach, but what we're looking for is being able to leave bone intact and do this as small as possible. And so typically globally you might have a little bit more than 10, but if you consider the size of the Asian frame and how big the endoscopic market is in the Pacific Rim, really getting something under 10 was necessary for us to have a safe and reproducible product. Keep going. And so, it comes down to a basic equation, that pressure or stress equals force over area. And so I'm, 200 pounds, I have a size 12 shoe. I walk out in the snow, I sink through the snow. I put on snowshoes, I disperse that 200 pounds over a wider area and I stay atop the snow. And so, obviously osteoporotic bone, much more like snow than say stone. And what we've seen is a lot of devices that edge load and point load and create, undue stress over too little of an area. And so FlareHawk represents, the ability to get in there and have less nerve retraction yet, or no nerve retraction in some cases, and maximum footprint, which have been two concepts that as our CMO, Dr. Boston, calls immiscible. And so FlareHawk really does reconcile those two things, to have something as minimally invasive as possible, but with surface apposition, bony contact maximized. Next slide, please. And so, as I mentioned earlier, the device was invented by an engineer named John Toe. He was a guidant cardiac stent engineer, just an absolute genius. And he had looked at the expandable cages and saw a lot of tire jacks, essentially cam-driven mechanisms with little room for bone graft, but primarily putting too much force over not enough area. And so using his stent background, he added flexors into a PEEK design. Initially, they were going to use a cortical bone because they were afraid of titanium, which is ironic, but went to a titanium shim for manufacturing tolerances. The two implants ride in tandem. And we know, talking to patients that have received FlareHawks, and some of whom have had coronary stents put in, that there's a great association with the stent for minimally invasive surgery, eliminating the big bypass procedure. And so over time, we will begin some patient education materials that really make that connection, in a compliant way. But we know that that has a great understanding from the patient base for stents. Next slide, please. And so, we preach around the integrity office: disc prep, disc prep, disc prep. You got a cool, sexy cage. It does a lot. It expands in multiple directions. But we're only as good as the disc prep that we're able to provide. So we've spent as much time, sometimes if not more, working our disc prep to be, no pun intended, cutting edge. And really, it's coming down to gardening through a picket fence. If you violate sort of those minimal insertion profile parameters to get your disc out or your implant in, really even for a second, you've kind of gone off the reservation in terms of really minimally invasive. And so we wanted to do all of the disc prep as well or better than surgeons are currently doing it, yet through a much smaller hole. And that's a daunting task. But we've got some expandable shavers and different curettes and different articulating devices that are just very thoughtful designs, working with our surgeon group. Right now it's going very, very well. And not just wholesale disc prep, but the ability to remove cartilaginous end plate through a very, very small aperture. And it all comes down to the side work, right? The central channel that presents through your aperture is fine, but then to maximize the bone graft, and then you're driving in with the golf cart, but you've got to kind of make a bed for a limousine. So there's more disc space than the implant. And again, with all that bone graft opportunity, a complete discectomy, can be done now with our disc prep tools through a 8.9 cannula. Next slide, please. And so, once you're there, what happens? And so, just having your cage be the only payload for graft, we felt was inadequate. A lot of instrument traffic or nerve traffic and pre-packing, was suboptimal. And because the cage is expanding in width, what we want to make sure is that the cage has room to expand. And so we wanted a device that really you could post-pack entirely. And so, we've achieved that. And we're, as I said earlier, variety of graft materials, almost everything, flows through it. It's a super wide aperture going in and also going through. It takes a little coaxing sometimes to get surgeons to sort of abandon some of the habits of pre-packing this space because of the need for graft and maybe some older devices that they had that did not deliver it. But and in this example here, we have one surgeon that was able to get about 22 cc's of cortical fiber. That's a great graft for us, and really just a hockey puck of graft in there from a very, very small hole. Next slide, please. And so, during our quest for CE mark approval, we were required to do a retrospective study, and the study criteria was, frankly, nothing that we were going to self-impose. We couldn't use any BMP or DBM or amniotic, anything what they called processed biologics. So it had to be unprocessed cortical fibers, cancellous chips, or local bone. And yet, we achieved 96.6% fusion rate with a 129 patient cohort on the Bridwell-Lenke scale. We were going to be measured for the CE mark approval, which we're in the middle of, against device-related nerve injury, expulsion or migration, subsidence, and end plate fracturing. We had nerve injuries, device-related TLIF nerve injuries around 4% in the literature, expulsion or migration around 2%, subsidence came in around 10% on average, and end plate fracture about the same, what we call settling. And so in our cohort, we were able to achieve 0% down the board. And noteworthy, 88% of these surgeries for this were done through a sequentially dilated some kind of port or aperture. And so super encouraging. Now, point of, in an abundance of transparency, this was the FlareHawk 9, but we strongly believe that this will be reflected in the 7 as well. And we almost made an all titanium FlareHawk off the bat. And it would have been a much more rigid device. And inherent to PEEK is obviously the modulus elasticity, but when you look at the FlareHawk, it's a two-piece construction. One of the things that we're studying now is we're seeing a lot of flex to the implant. And although we can't claim it as such yet, we strongly suspect and anecdotally feel that it's a very atraumatic delivery of the implant, a very atraumatic expansion into the spine, and just really treats the bone as gently as you could possibly ask. And so the data supports that. This was Dr. Dom Korick out of Charlotte, Dr. Raphael Roybals, and Dr. Mark Grubb. Dr. Greg Anderson out of Rothman was trying to get in the study, and we had some IRB issues and weren't able to get in time. But he ran his own cohort and came in with exactly the same numbers, 97.1% fusion rate and zeros down the line. And both of these will be published this year. Super encouraging. And nothing that we set out to do. It was completely serendipitous, but we'll take it. And so when this is published in October, we believe it'll represent the strongest expandable cage fusion data to date. Next slide, please. And so what's coming? Well, we're not going to, the titanium market, we believe has merit. We're very happy that we've kept this in PEEK. But, the market is sort of insisting on itself, certainly in the US. And so we looked at an all titanium device and we sort of lost some of the compelling nature of, the flex to it. And also the cost was more. And we looked at plasma coating and that had not had a great clinical experience. There was some delamination reported. And so we wanted something that gave us the PEEK, but yet the titanium. And there was a new process called thermobonding or vapor deposition, essentially where they put the PEEK shell in a vacuum chamber, hit it with an ionic field, and there's a thermobond that creates a 0.5 micron thickness of titanium. And so, you're getting the best of both worlds with a nanoporosity and the electrical charge of titanium, yet with the flex of PEEK. So there's a lot to study on this. But the delamination in the company is called N2 Bio. They have had no delamination. It simply doesn't come off. And so that will be out in December and with FlareHawk 9 and FlareHawk 7. So looking very good there. And I think the exciting thing is we have another expandable cage platform, the Toro device, which is an all titanium device with a mechanical that is biplanar. And, it has even... it boasts even greater expansion up to 75% in a width. It has continuous expansion to all heights from one device. And, it's getting to the point where our lateral project will be launched at the Q1, Q2 of next year. And as we work through it, we're working through a tube often. We've got some 3-bladed speculums similar to what's in the, you see in the market in the lateral. But the surgeons are now believing that they can do this endoscopically through a very small port. So lots more studies coming, prospective studies and benchmark studies. And just kind of a tip of the hat that we're looking for endoscopic solutions to not just the TLIF or posterior approach, but for a variety of approaches. So Max and Wolfgang, thank you so much for giving me a chance. It's a great pairing. The joke, beer and pretzels, chocolate peanut butter. Endoscopy and expandable cages go together very well, and you guys have been a great partner. And so thanks for giving us this opportunity this morning.
Hey, Chris, thank you. Great presentation. We already have the first question, so let me read them out real quick. I'm sure you and Mark, Kevin can answer them quickly. From Dr. Gardaki, has the study been accepted for publications? Can we reference it yet?
So, Wolfgang, the answer is yes. That has been accepted and will be published in the ISASS journal, we believe, in October.
Excellent, thank you. And then the second question was from Dr. Gonzalez. He's excited for the cage, it seems like, and asks when it would be available in the Mexican market. Are you working there yet?
Yeah, our VP of International, Jose Calleja, has the beginning process of the approval there, and we certainly can have him reach out. We've had some surgeons from the Tijuana area earlier that inquired during the Los Angeles NAS. So I know Jose's been working on that. I don't know exactly where we are with Mexico.
Maybe Dr.
In process.
Yeah, Dr. Gonzalez, we're going to answer that in writing if that's okay with you after the meeting. For the meeting, how we continue, we're going to have next Dr. Wagner out of Frankfurt and now Zurich as well. He's practicing 2 different practices. And after that, Dr. Hall, to the process. Dr. Wagner actually going to go to the joimax endolift static 3D printed cages, how he is using those endoscopically. We are really excited to see CE mark for FlareHawk and other expandable cages, which are nicely marrying to endoscopic spine in the German market soon. As we have had that conversation before, and Chris touched on that, return on investment in Germany is even much more critical to few, as simply the market doesn't pay that well, and we believe the integrity solution is going to be a key to really introduce expanding technologies into Europe. And yeah, we're looking forward to that. Prior to that, this is where the German market is and how they pushed it, especially Ralf Wagner, Bernd Illerhaus, Guido Ostermann, a few surgeons who really pushed very early on endoscopic assisted and endoscopic fusions through the Campbell's triangle. And yeah, we are proud that Ralf is presenting here on our behalf. So thanks again, Ralf.
Well, thank you very much for giving me the possibility. You all see the screen, I guess? Yeah. So the talk is about the endoscopic assisted fusion. We just had a publication on it, and actually there's a small video with that. It's on the eNeurospine. So whoever is interested can click on there too. Well, talking about the endoscopic assisted fusion, we had nice talk for the FlareHawk, and actually the access we are looking for is a little bit different to the normal endoscopic access, where we aim at the lateral recess. So it's a little bit comparable to a lateral T-lift procedure, coming through the neuroforamen and then aiming in the center of the disc. We heard about the Camden triangle, and we always see pictures about it. But when we take a look on the actual bony Camden triangle, it's far smaller because it's not limited from the exiting and the traversing nerve root. But you still have bone tissue, the facet joint in its size, depending on the length of the pedicle. So the actual Camden triangle is smaller. In order to get an implant through there, we have to work on the bone first, or we have to minimize the size of the implant. The best thing is to do both of it. Now, what is the difficulty when we're talking about the transforaminal approach? One of the difficulties is that we actually have to overcome the length of the facet. And this is comparable to a tunnel. When you have a long tunnel and you want to look through, you have to increase the hole, or you have to decrease the length of it. If not, you won't have the same visibility. So that means the first step of this procedure, and also for a lot of endoscopic procedures, is to open up the foraminal area, to create space in order to be able to work with implants and endoscopes in there. Now, for the procedure itself, I prefer to stand on the opposite side of my C-arm, the prone position. You can do it in local anesthesia or in general anesthesia. I would recommend, if you do it in general anesthesia, to use fast-acting muscle relaxants, so you actually have a feedback when you're preparing the neuroforaminal area when you're close to nerve. And be sure that your patient is positioned correctly. You can make a little bit of kyphosis in there to open up the foraminal area. Now, what are the indications? The indications are basically the same indications we have for the T-lift procedure, the MIS surgery. to start with, the best thing is to have a patient with a level L3-4 pathology. Due to the iliac crest, to the inclination of your instruments, it might be better to have a female patient. Anyhow, main issue is disc degeneration, disc herniation, or prior endoscopic surgery with recurrent with a recurrent issue. The important question you have to ask before you start the procedure: do we have a spinal stenosis? Are we able to treat that spinal stenosis with an indirect decompression? Can we achieve that indirect decompression with our implant, or do we have to decompress first and then position the implant? When you look at the planning of this procedure, the trajectory and the entry point is more medial to the midline. So it's comparable to a discogram approach, where you actually go in 45-degree angulation, and your goal is to bring in the needle parallel to the disc and aim at the center of the disc, so you can actually work inside the disc. Whereas when we work with a normal thesis procedure, we prefer a more craniocaudal direction. Another option, or I think a very important tool, is especially when we do with stenotic patients, or we have to open up the neuroforamen, that we actually position a Jamshidi needle as the first instrument. This allows us to actually dock on the SAP, and we heard it yesterday from Chris. The trans-SAP approach gives you the ability to actually open up the bony dimension of that neuroforamen by taking away the lateral part of the SAP. Then followed by the implantation of the K-wire, and you see the K-wire is a nitinol, more thicker K-wire than we're used to it. So it's actually a more solid K-wire, which doesn't break. At least I haven't made it break yet, and I almost broke everything which is possible in that tool set. So you see the K-wire procedure, and then the next step is the bone drills. So the bone drills are very interesting from the tool side, because they're blunt in the tip. That means that you need a certain size of neuroforamen to bring in the bone drills. There's an even smaller bone drill, a single-use one. I don't have it on the picture because usually I use it in those numbers from 2. You see there's 2 bars up to 5 bars. So I think it goes up to 11 and 12 millimeters. And you can turn it, bring it in. You don't have to respect the medial pedicular line as you do it with the sharp coronary reamer. You can bring them in more aggressively, but those tools are very aggressive. And I always push it a little bit into the medial direction, so I'm sure that I actually can take away the lateral edge of the facet joint. Then the placement of the needle and the K-wire in the center, bone drilling, and you see I overcome the apophytic edge of that disc space in order to create a tunnel. We heard from Chris that the tunnel is always easy to create. That's true, and I think it's important to decorticate the tunnel, at least at the implant, the first set of the implant is in a stable situation. You can open that up stepwise. You see it in the AP direction. And then you can take instruments and the endoscope in to bring out the disc material. So this is one critical step, and I'm always asked, how are you sure that you can take out enough disc material? It takes some time, and with the endoscope you can actually control it. With the endolift I'm showing you, I don't think it's necessary to take out as much disc material as we're used to in a T-lift procedure, because I believe that actually the tunnel preparation, together with the morphology of the implant and the 3D printed design, gives us a good bone implant edge and a good possibility for ingrowth. That's the position of the endoscopic working tube, and then in the prior time we actually used the dilator and then a working channel to bring in the implant. Now, when I used the bone drills, which are sharp on the side, I decided why should I put a working tube on it? I could do it looking at the design of the cage. It's not sharp. I could just bring it in over the K-wire. So what I'm doing now, because you see this implant is not expandable like we had the flare hawk design before, I bring it directly over the K-wire the implant. And you see this is the American design. So you can actually put a bone substitute or bone material or PMA on it. And they are there's different heights and different sizes. The old model is not wedged. There's also double wedge implant form, but basically you bring it in a oblique direction, and it has the possibility for restoring the lumbar lordosis. Now, at this slide, you actually see an actual patient. After bringing in the K-wire, taking out the disc material, I bring in the K-wire through the endoscope, so I'm sure I'm actually placing it correctly and medial enough. And then I bring in the cage until I have the bony contact. I try to rotate it in the parallel direction of my disc space, and then I hammer it in, and you see it slips actually nicely to the position. Once it's positioned correctly, you take out the instrument, and that's the final position of the implant. And then for the posterior instrumentation, you either take polyaxial screws. These are the joimax types. You can also think about using interspinous implants or facet screws. This is a little bit depending on your personal belief and your personal gusto. Now, this is after bringing in the 4 screws, so the final position has actually a screw and rod stabilization together with an intervertebral implant. And you see that the facet joints are still intact. We didn't do any harm on the multifidus muscle, so the only thing is opening up the pre-existing foraminal area and bringing the implant. And I think with this combination, you have a very good primary stability for the fusion. And what you see in this picture, in the lateral picture, is actually at the level of the L3-4. We have big foramen, but you see that the caudal part of the foraminal area has been nicely extended. After that, and that's the advantage when you work with the endoscope, you can make an endoscopic control, bringing it back in the working tube, and you can take a look on your implant with the scope. Here you see this is actually a concave formation of the SAP. Usually it's like this, so you can actually see that the lateral size of that facet joint has been decreased. Here is the pedicle area, and you see underneath the fat tissue of the traversing nerve root. This is the posterior ligament, left is cranial, and you can actually control the exiting nerve root to be sure there's no more impingement, and you have a good decompression here again, the pedicle and the lateral recess. Now, some pictures, postoperative scan. Close after the surgery, so this is only a few days after the surgery. You see the oblique position of the implant in the CT scan and the 3D reconstruction, and the incision. Actually, you see that the incision of the implant was smaller than the incision for 1 screw. Now, those pictures are a little more after surgery, so I think it was about 3 months after surgery. You see in this patient there was a slight listhesis, which has not been reduced 100%, and you also see that it looks like a little bit of subsided, but what you see also is that there's bony reaction close to the implant area, and also there is starting to get some bony ingrowth on the lateral side of the implant. Again, those patients were made without bone substitute, so only creating the tunnel, taking out the disc, positioning of the cage, so without any bone substitutes. And this is a picture 1 year afterwards. Again, a little bit of cage subsidence, but what you see is actually that the cage is completely integrated in that intersomatic space. And what is amazing actually is that you have a nice fusion next to that cage. Again, impressive because no bone substitute in the prior surgery. This screw is not 100% nicely positioned. Now, what are the pitfalls? We heard about it. The most, I think, the most important pitfall we should avoid is exiting nerve root damage. And I'm not talking about only damaging and destroying an exiting nerve root, but also creating dysesthesia, hypalgesia, dorsal root ganglion irritation, because this is very bothering for the patient. So the misplacement of screws, infection, bleeding, and cage subsidence, I think it's a problem of all MIS procedures. So it's not, in my opinion, it's not an important difference in between the endoscopic assisted fusion and other techniques. Now, cage displacement might occur. This was actually a patient where I did the cage placement first, and I wanted to do in a second surgery a few days later the screw placement, because we were running out of time, and you see actually this cage displaced into the foraminal area. The patient had a little bit of leg pain, but I had to revise it anyway. What I did is I went back in with the endoscope. I brought the K-wire back in, I hammered it back in, and did the screw placement. Now, some cases. This is a 70-year-old female patient with a VAS back of 8, and you see this patient is great because she only has an erosive osteochondritis on the level of L2-3, a little bit of interspinal problem, but not having any radicular symptoms. The planning, and that was done actually 5 or 6 years ago, so that's what I was talking about. The prior surgeries we always did with the working tube. This working tube was flexible, but bringing in this working tube always made me a little bit of stomach ache. And then the final position, not 100% central, but with a good posterior anterior stabilization. Again, intraoperatively control of that neuroforamen and the implant, as we saw it before here, exiting nerve root by turning the endoscopic channel. This is the exiting nerve root of L2 and the cage, and of course a clear decompression of that area. Postoperative CT scan we saw before. Now, this is a patient who was actually a very successful endoscopic assisted fusion patient. You see this monosegmental postoperative osteochondritis after, I think, open discectomy at the level of L3-4. The patient was under morphines, and this was the postoperative pictures after placing that implant. Only 4 weeks after, he only had a VAS back of 1 to 2 and went off morphines. You saw that the end plates were destructed by that erosive osteochondritis, so this patient is happy up to now. Now, one case with a multi-level endolift, you see this patient, she underwent all kinds of conservative treatment, under morphines, denervation, all inpatient rehabilitation, whatever, but you see the a clear indication for long-acting fusion. Actually, the segment of L5, this one was almost fused, so there was not a lot of mobility. So I decided to do a multi-level endolift procedure with the percutaneous stabilization. And even in those cases, actually, you have a good solution, and you don't have to open up the midline and decompress. The only thing which is left is actually 3 little incision holes from the placement of the cages. Next is another patient who underwent L4-5 endoscopic treatment. She had developed an L3-4 disc herniation, and you see here the disc is not 100% nice anymore. She complained about L5 nerve root pain together with back pain. So we decided here after L5, S1, 4, 5, decompression here on the right side. So we decided to put an Endolif in there. And this was a very interesting case. So again, 3-level. You saw the AP pictures before. You see the AP pictures before surgery. They actually start. She starts to get a scoliosis together with the rotation in that level of L3, 4, and 4, 5. And after placing the cages, only by the transforaminal approach, there was already a correction of this scoliosis. And I think that was very interesting because I never thought that we had enough footprint and enough possibilities to correct a small scoliotic deformity. So it might be an interesting option also for degenerative deformities. That was one of the first patients where I started to do the Endolif procedure also at the level of L5 S1. She had a big neuroforamen and a very low iliac crest. You can see it here. So that was the reason I tried to do that. If not, I would not recommend to proceed it at the level of L5 S1. After placing, and you see those postoperative CTs, she actually got a posterior fusion afterwards, but the cages are nicely positioned. They're in place. There's no subsidence. She ended up with posterior screw placement, but with a very good result. Also, it was a degenerative beginning scoliosis. Now to conclude it, I think you saw the different design in the implants. At the moment, I was working only with non-expandable cages, but I'm sure that with the expansion cages, where you can bring them in with them 7 millimeters, either in titanium or PEEK design, we have possibilities to actually use the normal anatomical borders and landmarks and bring in an implant in a safe area, which expands up to 12 to 14 millimeters, which should be enough for most of the patients. The critical factor is always the size of the foraminal area. So be sure that you work enough on that foraminal area that you start posterior, so your Camden triangle actually is big enough to place the implants. Ideal beginner's level is L3-4 or higher. Of course, those are very rare. So be sure when you start that you start with a patient who has not a big and very severe stenotic problem. The unilateral fusion might be possible due to the fact that the facet is not taken down. You have, I think, without taking down the facet, we have a good primary stability, especially if we combine it with a posterior screw placement. And as you saw it, the expandable cages, whenever they are on the market, I will try to use them because I think that's the future technique, and this will be the key opener not only for the endoscopic technique but also for minimal invasive fusions, especially in the American and also European market. Thank you very much.
Ralph, this was great. Thank you. We already have some questions. Let me just read them up for you, and maybe also Dr. Holt to answer some. Here, do you have any soft tissue concerns? That was one question which came up right away here, such as cernoma or infection with Endolif or any other of your cages.
Actually, what I see sometimes is that they have an hematoma, but if you see the size of that implant, which is about 10 to 12 millimeters, and you see the size of our bone drills in the normal endoscope, I don't think it's actually a soft tissue problem. Not more than for normal endoscopy, I would say it like that. I think one important thing is that we are closer to the midline, so that actually the way of our implant is not as far as from 12 to 14 centimeters away from the midline. I was a little bit concerned in the beginning if I bring the implant right through the skin and the muscle area that there might be some tissue hanging on that implant, but actually that doesn't seem to be the problem. Once the the working channel is created through the skin with the bone drills and also with my dilators. You can actually put your finger in there and it still keeps open. So I think that's not a big issue. I have never seen an infection so far. I think the sometimes a little bit difficult is that you actually stay with the rotation correctly, and that you have to do the first steps parallel to the disc, so avoid to work on the end plate of which is mostly the caudal end plate, to avoid creating actually subsidence. But that's in my opinion avoidable. What I do when I bring this implant in, I bring it first in the direction of the exiting nerve root until I have the bone contact. Then I turn it parallel to the disc and I hammer it in. I don't know if it's necessary, and it's a little bit comparable to bringing in the working tube, where you bring in the long sleeve first of all in the direction of the exiting nerve root, and then turn it under controlled circumstances.
To address the infection. Obviously, with any instrumented spine fusion, infection is the big concern. And with endoscopic discectomy and laminectomy, and now with fusion, I believe it's the constant irrigation that really eliminates the incidence or reduces the incidence of infection. If you think about it, the solution to pollution is dilution. That's what we learned when we were all interns. And you're constantly irrigating. When you run 3 liters or 6 liters of irrigation during the course of a case, I think that really cuts down. And in fact, the literature supports for open surgery, there's a lower incidence of infection when you intermittently irrigate the wound. So to take that to the next step, where you're constantly irrigating during an endoscopic procedure, I think that you're eliminating the seeding of bacteria that leads to infection.
Talk. I really enjoyed it a lot. I was wondering if you could tell us and the audience 2 things. First of all, we are obviously using the trans-SAP approach to remove a little bit of the, superior articular process to come away from the nerve root, exiting nerve root. But in your, first of all, other cases that you wouldn't attack because it's so collapsed with the endoscope, that you wouldn't, what are your contraindications? Number 2, what are your surgical moves to minimize the rate of dysesthesia, which is not 0%?
Well, that's a good question, Chris. So the key to success is always to work on the bone and stay away from the exiting nerve root in the beginning, which is easily when you talk about it, but in the patient this might be difficult. So first of all, considering that the approach is more closer to the midline, we actually have a bigger cambium triangle than with the normal thesis approach, number 1. Number 2, I think the goal to avoid it is to start more posterior, actually at the bone, as you described it, and we described it in our paper, on the tip of the SAP. That means even though we have a small cambium triangle, due to the fact that we are working on the bone and working our way inside the bone, it's almost a lateral position T-lift procedure rather than a transforaminal procedure. What patients do I avoid? I actually avoid patients where I have a high inclination and a very small foraminal area. I would say L5S1 patients, where you cannot actually bring it in parallel to the disc and you have a very large sized facet and a very large nerve or a ganglion inside it. Yeah, I would avoid that.
But you have developed like an interlaminar approach set. I saw that beautifully designed, and you've with joimax together, who have and again that's just to point out why the panelists are working with joimax. For example, Ralph, you have developed a system where you basically go from the interlaminar axis, and joimax has made this wonderful dilator and retractor set for you.
Yes, but it's not. We're still under. We are about to change some of the instruments with it. I think for the interlaminar approach, especially level 5S1, the key to success will be the biportal surgery. because we can actually use a retractor and control endoscopically when we bring in the implant. On the other side, the possibilities we have now is that we go through the facet joint and take away the SAP, but this is takes time. It's actually a time-consuming problem. And then, with the surgical solutions we have on the market, it's very easy to make a MIS TLIF at the level of, or PLIF at the level of L5S1. Why should we take 2 or 3 hours with less overview to do it in that way? But I think with the biportal technique, the level 5S1 is accessible and also in the same amount of time with the same overview, and also possibility to retract the S1 nerve root and the thecal sac and to see everything, every step you do. So I think the key to success will be the biportal surgery and for the interlaminar fusion techniques. Or the implant size, if we are able to have an implant size of 6 millimeters, I'm not afraid. But at the moment with the, an implant with 10 or 12 millimeters and almost percutaneous placement of the implant without 100% optical control, I'm not 100% persuaded.
It's actually a nice lead-in because Christoph and Ralph, in part of my presentation, I'll show exactly that, where you're able to introduce that L5S1 and via an interlaminar approach with resection of the facet joint. But I think, Christoph, your comment about what we teach when we teach a transforaminal approach for a discectomy or decompression leads us into the ability to resect bone in large Camden's triangle and allow us to safely place a cage so to avoid irritating the dorsal root ganglion or injuring the nerve root. I think your point is so important to drive home to the panelists that it's an evolution of the transforaminal technique that allows us to perform a fusion.
And then I heard one great comment. One more question I had for Paul, you, and then Ralph. Again, I'm probably the least experienced in lumbar endoscopic TLIFs. I do a lot of thoracic endoscopic TLIFs because I do a lot of thoracic fusions. But in lumbar spine, not so much. I wanted to hear your opinion about when I do lumbar ones, I typically go with the endoscope into the facet joint afterwards, decorticate it, and then pack it with the channel. Because I've seen that 2, 3, 4 years afterwards, some patients have fusion at the anterior column and have this minimal sort of like non-union in the posterior elements. And I've done bone scans on, again, minimal invasive TLIFs, not endoscopic. I haven't seen it with endoscopic yet, but I've seen patients that, again, have this constant irritation. And so I typically go in now with the endoscope into the facet joints, decorticate it, fill it with bone before I place my screws. Anybody has the same experience, or is it just in Seattle, the water maybe?
So if
constant rain.
I guess the real question is that if you have an anterior fusion, why do you feel the need to do a supplemental posterior fusion? If you have instrumentation posteriorly, doing the fusion of the facet joints is not necessary because you're going to have a big anterior fusion. There's much more surface area, and that's a much more robust fusion. So typically, I don't even bother with posterolateral fusion in whether I'm doing it open, minimally invasive, or endoscopically.
That's a good point. I was talking with Luis Pimenta about all that stuff, and the footprint of the XLIF or the extreme lateral fusion is an important event. Actually, what I heard out of his discussion is it doesn't matter what you put in, what kind of implant you have, as long as you have a good primary stability. So I think one key to a successful fusion is that you have a large enough implant which actually restores the normal height of the disc, so you avoid the primary movements and the primary instability effects, rather than bothering about the facet joint. But I wonder how you do the facet joint decortication on the thoracal area, because it's actually placed vertical. But perhaps you will show us some pictures about that. On the lumbar spine, I don't think it's a problem, but on the thoracal spine, actually, I would see it rather difficult to decorticate the almost vertical orientated facet joints.
Yeah, I don't do it in the thoracic spine because, the loads are very little. And again, I couldn't tell you the rate of MIS, T-lifts I've seen this, mainly with 2-level T-lifts. But basically, you have patients then, 3-4 years out, they have a very solid fusion in front. You get a CT scan, they get a bone scan, and they have just in the most posterior part of the pedicle screws have this tiny little lucency and associated back pain. Again, I have a handful of these patients. And so since I saw that, I now go into the facet joint. Again, the nice thing is you use the same, you basically just take the endoscope then afterwards, get the chamfer needle into the facet joint. You can even use the reamers and ream it out a little bit, then get in there, drill it out. It takes 10-15 minutes, but on these patients a year out, it looks really nice. And
that's interesting.
Doctor,
I don't have the data.
I believe it's perfect timing that we jump into Dr. Holt's presentation.
Sorry.
He's going to answer a few of the questions which already came up or are still not answered. So Massimo, tell us, ask a question. I believe Dr. Holt, you're going to answer. And every other question, we're going to spend as much time as needed after the call. We're not going to cut it short. One regulatory concern I want to just raise real quick, as the question came up a few times and Integrity asked me to point this out, is the flare hook cage is not yet CE marked. Okay, just for the recording here. They're heavily working on it, and we all are super excited. I believe you hear this. Doesn't matter if it's Latin American markets or the European markets. They're all waiting for an affordable, expandable solution. And Ralph, as you pointed out, with a very small footprint, 6, 7, 8 millimeters. And I believe their Integrity implants is really onto something, but not yet available. So let's give them some more months to figure that out, and they're really close. Just from a regulatory standpoint, I have to mention this. And yeah, Paul, it's all yours. We're super excited to see your first, I believe, expandable fusion and endoscopic assisted fusion with Integrity. Yes, excuse me, somebody else.
Hi, everybody. We are also very interested globally, also in the Asian markets, on the flare hook cage, okay? Just as everybody knows. And Chris Walsh, just wanted you to hear that. Sorry for that. Yeah, for the interruption.
Thank you.
All right, can everyone see my screen?
Yes.
Excellent. So I'm going to talk today about my experience using the flare hook expandable cage. And I'm going to take you through a discussion from how I use it in open cases and how I do it endoscopically. So, why are we even talking about expandable cages in general? And I think one of the most important aspects of achieving a successful outcome for the patient is the importance of a sagittal alignment. And so restoring lumbar lordosis has been shown in many studies to correlate with improvements of quality of life, because that's what we're really talking about. And so you can restore lordosis by either lengthening the anterior column or shortening the posterior column. And expandable implants give you the opportunity or maximize the potential to restore lordosis. And so that's why I think expandable cages are so important. And so, obviously there's multiple options to stabilize and decompress the spine. And all of these have advantages and disadvantages. I perform all of these surgeries. And so I'd just like to talk a little bit about what our options are. And of course, ALIF is an absolutely wonderful surgery, but there are certain instances where you don't want to perform an ALIF. Especially in the higher lumbar levels, it can be really difficult to mobilize the vasculature, and there is an incidence of vascular injury. And in men at the L5-S1 level, there is a 2% incidence of retrograde ejaculation. And so, that's something you really want to discuss with the patient. And so some people may opt to not have an ALIF. In the lateral access, with the XLIF and OLIF, sometimes there's access issues at L5-S1 and L4-5 with the hyaliac crest. Perhaps the person has had surgery before and it's going to be some scar tissue. There is a need for neuromonitoring, so therefore that increased the cost of the procedure. And even with neuromonitoring, there's up to 30% incidence of transient neurologic symptoms. OLIF, again, same issues with the lateral, but also at L5-S1 can be very difficult to do, and you need to use most people will use an approach surgeon for L5-S1. And as especially with training in the United States, these anterior approaches, utilizing an approach surgeon, the way training's going these days, there aren't very many general surgeons left. They're all fellowship trained to do one specific task, and getting a general surgeon to provide access in the future is going to be difficult. And then, of course, with a posterior approach, there is definitely the risk of dural tear. You require the smallest cage profile to insert it or to use, and there is a risk of neural injury. So these are reasons why you might want to not do these types of surgeries. So what I'd like to do next is just run through a couple of clinical scenarios where I've done open, MIS, and endoscopic cases. So this is a guy who's my age, who was a former MMA fighter, who has the worst luck imaginable. He started off with just a herniated disc following a match. And years later, a recurrent disc that led to a fusion, and then a motorcycle accident that led to another fusion, and then an adjacent segment degeneration with another fusion. And he had an L23 PLIF because he had multiple posterior surgeries, and then presented with this L12 disc extrusion above a previous multi-level fusion. And so, what are your treatment options? This is a multi-level fusion, so you have a giant lever arm and an adjacent segment disc herniation. So I chose, because he had already had previous surgery, I did a posterior procedure. You see in here, these were your standard anatomic peak cages by Medtronic, had a very nice result. And this is the L12 level. And I was able to perform the discectomy, and I used a bilateral cages. And if you think about the high lumbar L12, L23, there isn't a whole lot of space to place a cage. You have to do complete facetectomies in order to place your standard cage. And when you get much above, 8 or 9 millimeters, if you're putting in a static cage, that means that you need to get 9, 10, 11 millimeters in width, and you just run out of room. So I was able to insert the FlareHawk 7 at a profile of 7 by 7 millimeters and expand it to 11 by 11 with 6 degrees of lordosis. And if you notice here at L12, the profile of the end plates, you see that it very nicely follows the end plates, and it does create some lordosis. Obviously, I supplement the instrumentation with posterior instrumentation on all my cases. But here you are. This demonstrates the ability to insert a cage at a small profile to recreate lordosis and to recreate the disc space height in a single surgery. And if you talk about what the cross-sectional volume is, the area, this was an 11 by 11, 11 millimeter wide by 11 millimeter high by 26 millimeters long. The previous cages were 8 millimeters wide by 8 millimeters high and 24 millimeters long. You calculate the cross-sectional volume, that's a tremendous amount of volume and tremendous amount of support. And it actually approaching the size of an ALIF implant via posterior approach. So I think this offers a significant advantage if you're choosing to do a surgery posteriorly. But expandable cages are really not a new concept. There are multiple devices on the market, and all of them increase height. Some of them increase width, some increase lordosis, but few achieve all three, and even fewer are designed to be delivered endoscopically. There are some disadvantages of expandable implants because most of them expand only in one dimension. And again, you saw in the previous slide from Chris that force equals mass over area. And so if you increase the height only in a small area, you're creating focal stress, and that leads to microimplate fractures and can lead to subsidence, which is associated with a worse clinical outcome. In addition, some of these expandable cages, that the mechanism that is used to expand the cage takes up the space that you want for bone graft. And so you have less surface area for bone fusion to occur. And the mechanical devices are expensive to manufacture. And so, especially here in the United States, it's so difficult to get any new implants approved in hospitals because of cost. And if you have an implant that costs $5,000 to manufacture and companies need to sell it for $8,000 or $9,000, well, guess what? That implant's not getting approved in your hospital. So cost is a major factor. I'm just going to run quickly through these. You've already seen the FlareHawk 9 goes in at 9 by 9 millimeters, and it can expand up to 12 millimeters in height and 14 millimeters in width with lordosis of 0, 6, 9, and 15 degrees. The FlareHawk 7 cage, which can be delivered endoscopically, enters at 7 millimeters by 7 millimeters and can expand to 12 millimeters high by 11 millimeters wide with up to 6 degrees of lordosis. So let's talk about an MIS TLIF. This is just a garden variety isthmic spondylolysis, bilateral pars defects, and a right-sided foot drop. So, I mean, pretty straightforward clinical indications. What are your treatment options? You can do standard PLIF. Some people might consider just doing an endoscopic foraminotomy. An ALIF would be a good case, reason to do this case. I chose to do an MIS TLIF. And I just did a tubular decompression with complete facetectomy to open up the area to place the FlareHawk 9 cage in this particular case. I used a standard end plate preparation with curettes and pituitary rongeurs, and then place the cage. And of course, I supplement with the posterior pedicle screws. I use image guidance. But if you notice here, you see the tantalum markers on the peak part of the cage. They really expand, and I was able to recreate the lordosis and fit the profile. And one of the important concepts, or one of the things that I came to realize, is that if you put lordosis into these cages posteriorly, it's a reverse wedge, and it's going to really resist posterior migration. So you're not going to see migration of these cages posteriorly because you've basically creating a reverse wedge. I think that's one of the other advantages of the expandable cages, with the ability to restore lordosis, and by definition, then that resists cage back out. So here's the O-arm images, seeing the placement of the cage, very large footprint for a single cage, and the amount of bone that you're able to pack. And what happens is it comes out both laterally and anteriorly, and you can really pack a tremendous amount of bone in here. It's extremely important with the expandable cages that when you do your disc space prep, that you need to take more disc material than you would normally, because you need to give space for the cage to expand, and you need space for the bone graft. So whereas with the titanium implants that where you don't need to, the static titanium implants where maybe you're relying on bone growing into the cage, you don't necessarily need to do such an extensive discectomy. I think it's of paramount importance with expandable cages to do a very wide discectomy. So this brings me to endoscopic surgery, and this is where my true passion lies. And we'll talk about both the transforaminal and interlaminar applications. So obviously, we've all talked about what some of the challenges are, the constraints of Camden's triangle, the bony constraints. There's some geometrical constraints of the tubular retractor and the endoscope. So, what we're trying to do is fit a square peg down a round hole, and that creates some geometric challenges. And of course, with the endoscope, how do you get instruments down that are going to effectively remove disc material in an efficient manner? Because really, if we don't have good end plate preparation, it doesn't matter. You're not going to have a good outcome. And then, of course, you need to be able to deliver a significant amount of graft material in order to get a fusion. So with the transforaminal approach, obviously we tried to design an implant that can be delivered safely through Camden's triangle, but at the same time having the largest footprint to avoid subsidence. And also we need to design instruments that can effectively prepare the end plates. So again, showing here the expandable cages. We've already had this slide. But let's talk about the access. So we've designed some tubular retractors to facilitate the deployment of the cage after you've performed your decompression. And I have a nice little animation to show you. Again, utilizing the concept that joimax, we teach in the joimax courses, especially with the interlaminar and the transforaminal approach, where you utilize the bevel of the tubular retractor to rotate and retract the dura or the exiting root out of the way so that you can protect it when you're removing disc material or inserting the cages. So obviously, I think the most important thing is the end plate preparation, and there's shavers and curettes and things. And one of the epiphanies that I had was that, we've been trying to design all these instruments to work down the working channel of the endoscope, but that limits you in the working area that you have of the instrument. And I said, well, if we're utilizing the tubular retractor as a retractor, why can't we just place an instrument into the disc space and then place the endoscope over the instrument? So rather than placing an instrument down the endoscope, why don't we place an instrument up the endoscope? And that was the epiphany that we had, and we've designed all these instruments between articulating curettes and regular curettes and wire brushes to work in this manner. And in fact, we've applied for a method patent for that concept of working up the channel rather than down the channel. I've been working with joimax to develop a spinner, which I'm going to show next. The shrill spinner, which, if Dr. Wagner can have Wagner's arch, I think that somebody else should get something for them. And since this is my talk, I get to say whatever I want. So I'm just throwing that out there. This is under development and not yet for sale. But as you think about how we can remove disc material in an efficient manner, wouldn't it be nice to have an instrument that inside the disc space can spin and morselize disc material? And the inspiration for this came when we were last summer, we were sitting on my boat making frozen mudslides using the Ninja blender. Why can't we morselize disc material and just irrigate it out the endoscope? And so using this spinner to morselize, or using this hooligan, to morselize disc material and irrigate out may speed up the process of removing the disc material. And the ability to articulate and wand within the disc space will help for efficient removal of disc material. But this is under development. It's not yet for sale, but hopefully it will be coming out soon. So this is we talked about what the advantages of being able to use the endoscope, and this is in one of my endoscopic fusions. In the very early stages of disc material removal, you can actually see the interface between the cartilaginous end plate and the bony end plate, and this was just with the regular disc shavers. Obviously, there's a tremendous amount of more work to be done here, but I wanted to show you the interface here and what you can do and what you can see inside the disc space when you try to prepare. So before you deploy a cage, you have the ability to go in and inspect the end plate. And I can't remember if this is my case or Dr. Gardaki's case, but you can actually see the amount of bony end plate removal that you can achieve. And it's nice to be able to use your endoscope to inspect before you deploy a cage. So the way I envision the transforaminal deployment of a cage is, just using the standard joimax technique that we always use with the reaming and drilling to actually enlarge the bony constraints and enlarge Camden's triangle. And then, like what Dr. Wagner was saying, to get into the disc space, it's not the same approach. It's a little bit more steep. And so we want to be able to redirect and enter the disc space. And we can do that by inserting a guide wire into the disc space under direct visualization, remove the smaller tubular retractor and insert a larger one that's more amenable to placing a cage. And so as we employ that larger tube, we can protect the nerve root and dura and visually inspect the disc space. And then after the disc space prep, and we've determined, we can then insert the flare hawk cage, the expandable cage, and then post-pack with bone. The ability to introduce lordosis is also very important, because now you have the ability to restore normal anatomic alignment. And here, just the standard joimax technique, we're protecting the dura, and we're far away from the exiting nerve root, and the ability to expand in both height and width and introduce lordosis, and allows us to put a tremendous amount of graft material in. So that's how I envision the transforaminal case to go. This is how we design the technique, and this is actually putting it into practice. So here's a lady with a third recurrent disc herniation at L4-5. Not that impressive in the axial, but she had a foot drop. I had performed 2 tubular MIS surgeries in the past, and so coming in transforaminally to resect that disc with avoiding all of the scar tissue, again, another advantage of the joimax transforaminal technique for recurrent disc herniation, you can avoid all that scar tissue. So here you see the tubular retractor from the joimax technique, and I've done the discectomy, so I've done the decompression. And now, after performing that, I redirected, inserted the slightly larger tubular retractor that has an outer diameter of 11 millimeters and inner diameter of 10 millimeters, inserting the cage, this with the expandable PEEK cage with the shim, so the outer shell, the inner shim. And this is the post-op CT, intraoperative CT, I should say, from the O-arm. But look at the size of the cage. It's a pretty significantly large implant delivered via an endoscopic transforaminal approach. Intraoperative X-ray showing the size of the tube, the amount of space for the exiting nerve root, and we're protecting all of the neural structures. Oops, let me go back to that. And this is the post-op X-ray showing the cage and the posterior stabilization. The interlaminar technique is the standard decompression technique using the joimax interlaminar that Christoph and Ralph have really shown us how to do. But there isn't a whole lot of room to insert a cage, and so I was thinking that if we inserted a retractor that had a very exaggerated bevel, that would expose more facet, and you'd be able to rotate the bevel to retract the dura and expose the facet, and then ream the facet to give yourself more room, and then redirect to get a better trajectory. And this is what this animation shows with the exaggerated bevel, rotating it so that we push the dura out of the way, and then taking those side cutting drills and just slowly, multiple passes, retract the dura out of the way to get a better trajectory. And here you are, Ralph, if you're L5-S1, imagine doing this bilaterally, inserting cages, Flairhawk 7 cages, and expanding the amount of surface area that you'd be able to support, and the amount of graft material you'd be able to place in the intervertebral space. But by doing it endoscopically, you're able to visualize the nerve root and resect facet and give yourself enough room to place the cages. And that's exactly what I did. Here is an interlaminar case. The Flairhawk 7's deployed, and as I withdraw the retractor tube, you can see how the dura was retracted. So why expandable cages here? I just demonstrated one implant system that allows me to deploy a cage using open, MIS, and endoscopic techniques, based upon what's best for the patient. There isn't one technique that's best for all patients, and I like to have options. The concept of the adaptive geometry of the cages conforms to the end plates to give you a lot of surface area that reduces the risk of subsidence. And I think obviously expandable cages will give you the opportunity to restore lordosis and sagittal balance while putting the largest cage possible with the smallest insertion profile. So in my opinion, and I really believe that the endoscopic decompression in combination with the expandable cages is an extremely powerful tool that it gives us a 360-degree fusion through a single approach performed by a single surgeon. And I think that's important. And the reality is that now this makes outpatient endoscopic fusion a reality. So thank you. Just like for everybody that's watching, I have a Facebook group called the joimax Endoscopic Surgery Group. And it's right now we're over 400 surgeons from around the world, and we post cases and pose clinical problems, and it's a really good opportunity for people to show their work or ask questions, because some of the people that have done the most cases in the world are on this group, and answer questions if you have a clinical problem. Also, my YouTube channel, I have lots of how I do it videos where we do some clinical problems like targeting, or why do you even want to do it? How do you use the shrill? I keep trying to get Ralph to do a video, but I can't get through to, I have to go through his people, and his agent won't let him talk. And again, we talked about the SPAR discussion. Dr. Gardocki and Dr. Derman are both endoscopic spine surgeons. We're going to talk about indirect and direct decompression, and I'll send you guys all the links if you're interested. So thank you.
Well, great talk, Paul.
Thank you.
Yeah, thanks, Paul. Ralph, Chris, for the great talks today. Let's wrap it up with some questions. Ralph, you wanted to answer live the question L4, L5 nerve root damage.
Yeah, well, that's a good question. But actually, the principle is the same as for the endoscopic normal endoscopic decompression. So to avoid exiting nerve root damage as well as traversing nerve root damage, is that you actually create space in the foraminal area and keep the first approach tools more posterior, so that you don't enter the disc lateral to the facet joint. That's the most dangerous situation, is that when you actually have your first approach tools and the dilators as well as the reamers lateral to the facet joint. And again, I go back to the trans AP approach. So be sure when you do that to start, especially for degenerative cases, to start more posterior. And I learned that from the L5S1 area, where you always two anterior, no matter where you enter it. The reason why is that you have a large facet joint size in width, and also short pedicles. So it's the same thing. You have to restore a normal anatomy so you can place your instruments, and I think that's the way you avoid it. One big misunderstanding is that the far lateral approach, you have to be very careful, because the far lateral approach that is actually reducing the three-dimensional dimension of the Cambion triangle, and puts pressure on the exiting nerve root. So be sure you start a little bit cranial in caudal direction, and you stay posterior.
Yeah, Paul, also from here, a fantastic talk. Quick question for both you and Ralph. After I deploy the cage and retrofill the cage for my cases, I typically also take a quick peek at the foramen and the canal. Again, I do mainly thoracic fusions, but do you guys have you guys seen any retro of any flow into the canal of bone graft? Because I've seen it like once or twice, and for that reason, I always check again on the way out the canal. And I think, Ralph, Paul, I think you kind of showed it on your video, but when you go transforaminally, do you typically put the scope in one more time, making sure you see the exiting nerve root, traversing nerve root, and there's no bone graft?
Yes, thank you for reminding me. I knew I forgot something, but yeah, no, that's actually, I think, of paramount importance. Inspect your work. You want to make sure that graft material hasn't extruded out where it shouldn't go, or in deploying the cage and expanding, that maybe some disc material didn't make its way into the canal or under the exiting root. So absolutely, that's a great point, and I always do it.
I always do that too, Chris.
Okay, cool. So, thank you. Amazing talk, Paul. It's really, I think it's very, very convincing. And I think one thing about the flare hook, which I like, is it basically corrects our channel discectomy, where we typically do violate the end plate a little bit at the middle with the drills, and it kind of puts the hawks into the side of the end plate that were not destroyed by the surgeon. And so I think that really helps too. So I'm very curious about the long-term results. It's going to be fun.
I agree.
Yeah, unfortunately, Chris isn't on there anymore. We need the CE marking so we can use it actually.
Well, I'm here. It's we're in the final stretch, but and Dr. Hofstetter, you bring up a great point. In fact, we have surgeons that now they can feel like potentially that the bone graft bone growth factors that are coming.
Chris, we are losing you there.
Chris, I hope the CMAR comes better than your connection.
Fair point.
Tough crowd.
Yeah, well, I just this is a great forum, and I'm just really thrilled that we could all get together. And I really want to thank Wolfgang and Max and Chris for putting this all together. I just love interacting with you guys. It's just so much fun. And even when I participate as a panelist, I still learn something every time I listen to you guys talk. So thank you very much.
Yeah,
Thanks again to all the speakers. Paul, thanks for the nice words. Coming up next, we're really happy to announce that we're going to do an Asian Pacific Latin American webinar. Similar setup, going to be announced in the next 2 to 4 weeks. And looking forward to seeing many of you again. And till then, we have the SPARS meeting, 15th of September, hosted by Integrity Implants, sponsored by Integrity Implants. Yeah, thanks again for joining, everybody. Look at our calendars online at the homepage. Stay updated. There's a lot going on. Have a great weekend. Bye-bye.